I'm going to be taking you through some data that our team have pulled together. I'm going to compare other countries to actually the what's going on in British Columbia, but also in Ontario, which is the province I'm familiar with, and what's interesting to me is that, within Canada, there are actually a lot of differences as well, and we can learn from each other in the different provinces. As I do that, I'm also going to integrate data you'll see from something called the Commonwealth Survey. So the Commonwealth Fund is a nonprofit organization in the United States that helps to compare countries, and they do international surveys of both the general population as well as primary care physicians on regular intervals. And so the data that I'm going to be sharing with you today is going to be coming from surveys done in 2019 and 2020 of primary care physicians and then the general population. So to start, I wanted to share this slide with you that really positions how Canada is faring compared to a number of other OECD countries that actually have higher primary care attachment. By attachment, I mean, this is a question that's often asked in the Commonwealth Survey. Do you have a regular doctor or a place of care? The blue on this graph is the proportion of people who said, yes, we have a regular doctor. The orange is the proportion that says, yes, I have a regular place of care. You'll notice there's a decent amount of orange in the Canadian column. And just to clarify that, I think sometimes people actually who see walk-in clinics end up saying yes to having a regular place of care. But what you can see here is that we've only put on this graph countries that have 95% or more of their population saying, yes, we have a regular doctor, GP, nurse practitioner, or physician assistant, or a regular place of care. And in most cases, I think it's a GP with some NP and physician assistants as well. So how does Canada compare to these countries in a couple of different, in a few different metrics? So our team actually looked at a whole bunch of metrics, but I want to highlight two for you. One is, interestingly, Canada does seem to have about the same number of GPs per capita. So given our population, we have roughly about the same number of GPs. We're kind of in the middle of this group of other countries that have a higher portion of people attached to a primary care physician or practice or clinician or practice. So there isn't a difference, it seems there. That's not what's driving, it seems, the issues. But what we see when we dig deeper is actually Canada does have fewer total physicians. So what you can see on this axis is the total number of physicians per 10,000 people on the x-axis. And then on the y-axis, you can see the percentage of people with a regular primary care clinician or place of care. So of course, these are all the other countries where we said they have higher rates of attachment. And then the red circle is Canada. And you can see that Canada actually has fewer physicians per capita than these other countries. So what's going on? Well, we have to kind of put this into context. The numbers can be misleading. Not all family doctors are practicing comprehensive longitudinal office care. And so when we're looking at our family doctor proportion in Canada, or family doctors per capita, we have to remember that in Canada, that's actually including a lot of family doctors that are doing other kinds of work. So about 30% of family doctors in Canada practice in specialized areas. So that could be emergency medicine, sports medicine, and of course, some of them are working in walk-in clinics, so not providing comprehensive longitudinal office care. So part, I think, of what's going on here is that we have less physicians per capita, and what we're doing to some degree is relying on our family doctor workforce to fill in some of that gap. So a lot of the emergency department care offered in Canada is actually done by family doctors. As an example, many family doctors work in hospitalist medicine, etc. So I think part of the answer here is that we probably do need more doctors. But as we've heard before, and we're going to hear more, it's not just about having more doctors. And there's many reasons for that. For one, I don't think it's actually a realistic solution. I have colleagues who've actually kind of done the math around the aging population, more complex needs, and the number of doctors we have, and that we could reasonably graduate in the amount of time that takes. So for one, it's not a fully realistic solutions, but we need to kind of think about that at the long term and build the capacity for the long term. But we also have to think about other things, because more doctors alone won't get us where we want to be. And so one of the interesting pieces when we look at other countries is, we tried to pull together, this is a summary slide of the different other factors that are affecting, we think, why countries have high attachment or high proportion of their population having primary care. So interestingly, some of it just comes down to funding, we think. So a higher proportion of the total health spending is public in these other countries. More of the total health spending is on primary care. And then some of it comes down to system organization. So in some countries, as we'll talk about, they actually require or they really help patients to register with an individual clinician or with a practice. And often they're really encouraging people to get care close to home. Many of these other countries also have a lot more accountability. So there's accountability of the provider to the health insurer, and the health insurer can help direct where it is that the provider works and what kind of work they do. And in fact, most of their workforce, family doctor workforce, is doing office-based general practice as opposed to specialized or focused practice. And then there's also all the practice organization and physician payment. So they have lots of other health professionals that are integrated, and that's happening not in all of the countries, but it seems to be a trend where more countries are more and more trying to integrate other health professionals into primary care. Most of these other countries, they have capitation, maybe salary. And interestingly, we'll talk about they have organized after hours care. So we can talk specifically about that in a moment. And then they also, though, have very few walk-in clinics. So they don't have their primary care workforce spending their time in walk-in clinics. They're really focusing their primary care workforce on longitudinal primary care, ongoing relationship. And there's sort of an expectation that the primary care doctors during the day are going to be able to provide timely access. And then we'll also talk about how the information systems can be a little bit different too. So they've got much more functional information systems. Let's go to that first point about funding. This is a graph that just investment in primary care, the amount of. And what we can see here is Canada spends less on primary care services than 22 comparator OECD countries. So 5.3% is in Canada of the total health budget versus 8.1% of these, the OECD average that you can see here. So Canada health spending on primary care. So how about some other ways in which Canada and BC might be different from other countries? So interestingly, like when you think about Finland, patients are actually automatically registered to a local clinic. And in Norway, they're automatically registered to a local GP. Now, this doesn't mean that they don't have any choice. I think, for example, in Norway, I think they have they can change doctors up to twice a year, provided that the doctor they want to see has availability, and if not, then they can go on the wait list for that other doctor. And similarly, in Finland, there's sort of a period of time during which you're able to change your health center, but you're automatically registered the one that's closest to you. Basically, in other countries like the UK, they don't automatically register people, but the local clinics have to accept you if you live in the area. And in the Netherlands, there's the choice, but basically, like they're really strongly encourage connection with a local practitioner. And if the local practitioner is full, the insurance company actually helps you find ones. The Netherlands is a bit different. They have complete coverage, health insurance coverage across the country, but they actually have 4 health insurers who compete with each other, and this health insurers, it's their responsibility to make sure that you as a citizen of the Netherlands have a GP. And it's strong, and you basically have to see the GP in order for you to access anything else in the system. So contrast that to BC or other parts of Canada. Generally, people are left to find their own family doctor. In BC, it does seem that many divisions of family practice offer a service to connect patients to a family doctor. But my guess is that, that there aren't necessarily doctors to always connect to there. I know in Ontario, we have a centralized provincial matching service, but people actually in Ontario wait for many years on a wait list. So the other piece that we should though mention is that partly there is a bit of a trade-off. So I will say that in some of the countries that where you're registered to a local clinic, you may see different doctors who work in the same clinic. And so in particular in Finland and the UK, where that happens, there actually is a less emphasis on continuity of care. And that's fallen by the wayside. And many family doctors don't like that. Many patients don't like that. However, at the end of the day, everyone does have access, and everyone does seem to have also timely access when they need it. In the Netherlands, in Norway, they have managed to make the system such that they do have they do still prioritize that continuity of relationship. The ongoing relationship with a family doctor or NP is really prioritized, I would say, here in Canada and BC, which is great. However, I'm starting to learn more that there's been like a real growth in walk-in clinics and urgent care centers, especially over the pandemic, as people don't have family doctors. And so I worry that many people now are getting what I would say is not really full primary care, but they're getting the primary care they can through walk-in clinics, and that's not prioritizing the relationship. As I mentioned, these other countries encourage primary care close to home. And in Canada and BC, you can get care anywhere. And sometimes people actually have to travel a long distance to get that care. So how about teams? So interestingly, like in Finland, nurses are the first point of contact. And in many other countries, nurses actually independently provide some care, like baby visits. Immunizations are done by public health in the UK, for example, as well. The health professionals, as I mentioned, are increasingly part of the team. Interestingly, physiotherapists and psychologists are the ones that are most integrated into, or two of the types of health professionals that are very integrated into the Finnish system. Contrast that with BC, where there's a very small proportion of people who have access to team-based care. I couldn't get an exact percentage, but everyone I spoke to in BC said it was very small percentage. So you can see the kinds of practices there that offer a team-based care. Their primary care networks do have team resources, but they're really shared between a lot of practices, and it's not really the same as the kind of team-based care that's often referred to in the literature or in the studies. In Ontario, actually, and even here in Quebec, I would say there's a lot more higher portion of the population compared to BC that have access to teams. Does it work perfectly? No, there's lots of things we can talk about how that needs to change, but there are a higher proportion of people who get their care in a team, both in Ontario and Quebec. Although I would say there isn't as much of a culture of delegating the care entirely to other health professionals. So for us to, really leverage a team, I think we're going to talk more about that. I think that we have to start to think about how can we do things efficiently so a patient could come in, for example, and see an NP or see a nurse or a social worker and never have to see the doctor, as opposed to seeing a nurse and a doctor, which doesn't necessarily take work away from the doctor, doesn't open up the ability for the doctor to see more patients. So I mentioned there's also differences in after hours care. So really interesting. So in Netherlands, Norway, and many other countries, they have this really organized regional system where doctors within a region of, let's say, 100, 200,000 people, they collectively provide after hours care to the population. They rotate through. So because there are many, many doctors serving many, many patients, it's not too onerous in terms of how often you have to do an evening shift. And when you're doing an evening shift, you're actually supported by a nurse who helps to triage people who call in. And interestingly, it's a one number to call for the whole region. So patients always know what number to call. If they need care after hours, they call this one number. The nurse triages them, tells them where to go if they need to be seen in person, or maybe defers it for the next day, or would send them to the emerge if that was appropriate. So they triage them, and in the Netherlands, they even have a driver who can take the doctor to the house to do a visit if that's what's needed. And as I mentioned, they have fewer walk-in clinics. So they don't need walk-in clinics because they have this organized after hours, and because they really have some accountability for timely access. So in BC, like, to contrast that, it seems that there isn't a contractual requirement for practices to provide after hours care, except maybe in a very small pilot model that's out there for a few docs are a part of. There are, of course, many walk-in clinics. In Ontario, there actually is accountability to provide after hours care, but there's variability on how that's implemented. So practice organization and payment. Dr. Christy Newton talked about that in BC, and there's of course been some changes. But I will say that, in other countries, many physicians are paid mostly by capitation, while some are salaried employees. And there are also financial incentives for quality, for example, in the UK and Netherlands. In BC now, it's nice to see that 80% of physicians are just in the last few months have signed up for a new funding model. So I think this may really change the landscape. And this new funding model seems to be like a mixture of some hourly amounts, as well as an amount per patient per year, as well as an amount for pay by the visit, and it also pays for administrative time. So it's a unique payment model, and I think many people are watching to see how that's going to impact care. There does seem to be incentives for doing quality improvement, but no targets to actually achieve. So not like you're held into account to measure timely access. I would say in Ontario, many doctors are paid by capitation as well now. And I think we're trying to shift more and more to that. So the government has recently opened that option up more. But there are actually, I think, more incentives and more reporting requirements related to some quality measures. In other countries, some physicians own and operate their own practice. So it's very much like self-employed physicians, just like it is here. But there are other countries, like in Finland, where there is a health center really owned by the government and run by the government. So mostly in BC and in Ontario, primary care clinics are really like they're small businesses, often run by family doctor themselves, although in BC, I'm told that more and more are run by non-physician or corporate owners. So then there's accountability and governance. So strong incentives or accountability for quality of care in the UK and generally, and then also same-day access specifically for UK and in Finland. Contrast that like there really isn't that kind of accountability, I would say. It seems like in BC. In Ontario, I'd say the team-based models have some accountability. They have to report quality measures back to the government. Nothing bad really happens if you don't meet those measures, I would say, but you do have to report on your quality of care. There is accountability in other countries about where doctors can practice and kind of what their scope of care is. So at the end of the day, doctors kind of have to get the permission from the insurer, for example, in the Netherlands, to say, yes, you can set up a shop here and just, practice and do your family practice. When I asked them in the Netherlands, do you guys have sports medicine physicians there? And then the answer that I got from our expert interview that we were interviewing was, well, like, which insurer would just pay for a family doctor to just set up a sports medicine clinic? Like, that wouldn't make sense. So, I mean, interestingly here, our doctors can practice anywhere and choose anything in terms of their scope of practice. You could have a clinic that's just doing kind of vein therapy or sports therapy or just psychotherapy, and then just bill the government and get paid. So there's a lot of autonomy for physicians in Canada, both in BC and Ontario. And as we talked about, a large portion of our workforce does do specialized care versus in other countries where most family doctors are doing family medicine. So, I think just in the interest of time, I'm going to skip through this, but just to say that 80% of doctors are really operating independently their own practice. and most of them work in groups. And just to say that, in general, groups are more likely to do things like offer appointments on the weekend and use electronic medical records and use team-based other health professional members. So there's lots of reasons why groups are a good idea, but we see but whether the group, I would say in BC, it seems that many doctors do share kind of a location, and maybe they share some staff, but they don't necessarily always cross cover for each other. And we talked about this in the Our Care survey results. So interestingly, so you can really see this when we look at the Canadian data compared to the Commonwealth around whether practices have an arrangement internally or with another practice where patients can be seen by a doctor or nurse when the practice is closed. And we can see Canada, only 49% said family doctors said yes, compared to 75% in the Commonwealth average. So these are 11 other countries that we're being compared to. And in BC, it was actually even lower than the whole of Canada, it was 37%. I will just say timely access is also a big problem in Canada, but I'm not going to go into this in a lot of detail, but we've talked a bit about this before. I do want to spend a few moments just contrasting information technologies. So in other countries, some of them have very well-developed information systems where they can securely message doctors and patients, and where patients can book online. So the Netherlands is a great example of that. The UK and the Netherlands also have some really good electronic systems that allow you to manage care proactively. So what do I mean by that? It means you can easily kind of use the system to say, oh, which of these patients have diabetes? How many of my patients with diabetes have come in the last year? How many have had their blood pressure being read? You can do that quite easily with the systems in the UK and the Netherlands. It is harder with electronic medical records and the way they've been set up in Canada, I would say in Ontario and BC and other provinces. Not all provinces, but I think many provinces. Interestingly, like, in Finland, patients and other healthcare providers can easily access their own health records. So there is sort of this central patient record, and that's unfortunately just not a reality in Canada, broadly speaking. So this is just a snapshot to say that the problem isn't that we aren't using electronic medical records. In fact, in Canada, this is a bit older data, but it's of 2020 or whatever, 86% of people, of family doctors in Canada say they were using electronic medical record. So the majority, and BC was as high as 90%. So we are using electronic medical records, but the EMRs aren't as functional and integrated with other parts of the system as they are in some of these other countries. And that can lead to a lot of inefficiencies in practice and frustration, both for patients and for doctors. So this is again, comparison. This is family doctors reporting on this. And you can see that Canada is really at the bottom here, at the bottom on one and near the bottom in the other in orange. So the first question is, do you offer patients the opportunity to communicate with your practice via email or a secure website about a medical question? And in Canada, it was only 23% compared to all these other countries where it was much higher. 65% was the average. And when asked, can you request appointments online? In Canada, we can see, I think that's about 22% maybe. And the Commonwealth average, I think, is about 56%. Sorry that this slide got transposed a bit differently. So I'm going to just skip over here. And then, this is interesting because this is family doctors reporting, can they electronically exchange information with doctors outside of their practice? And what you can see is very few doctors saying that they can electronically exchange information, whether it be patient clinical summaries, laboratory and diagnostic test results, or lists of all medications taken by an individual patient. The Commonwealth average was about the 60s or mid 60s. Canada somewhere between 25 to 30%, and British Columbia generally seems to be at or below the Canadian average. And then interestingly, this one here is just about physicians using personnel to care for those with chronic conditions. So nurses or nurse case managers. And what we can see here is that Canada, much less likely for family doctors or primary care practitioners to report that they're using other health professionals to monitor and manage patients with chronic illness like diabetes or hypertension. We know that that actually helps to provide better care. And what we can see here is that overall, BC, so overall Canada, I think it's, again, these percentages are a bit messed up, but I think it's about 60-ish%. And then what you can see here in BC, actually, it's lower than the Canadian average at 43%. So one thing I just do want to mention, I've showed you a lot of data from this Commonwealth Fund survey that's done. For some reason, the Commonwealth Fund does not have a question about relationship continuity in primary care, which is such a foundational aspect. This diagram on the right, which I think Christy might have showed as well, really just shows that, people who have an ongoing relationship with one physician, generally they get better quality care, they cost the system less, they use the system less, and they actually live longer. And so and I would say historically, making sure people are getting a relationship-based primary care, having high relational continuity is something where Canada has done well. So most people in Canada, if they have a family doctor or NP, they're seeing that same person again and again over time, as opposed to seeing different people in a practice. However, as I mentioned before, I'm a little worried to hear about that rise in walk-in clinics and urgent care centers potentially threatening that. So just a little caveat that I haven't shared data on this because there isn't good data, I would say internationally to share. So in summary, some key points: we spend less on primary care as a proportion of our total health budget than comparison countries. We have similar numbers of family doctors, but fewer doctors in total. And more of our family doctors are doing specialized work, and more of them are working in walk-in clinics than compared to countries where they have a higher proportion of the population attached to primary care. These other countries seem to organize care differently. It's more geographically based. Physicians have more accountability. There's more teams, there's shared after hours, and there's definitely better use of information technology. And there can be some trade-offs. So I'd say some of the countries have traded off being able to be attached to a place with continuity of care in particular. So there does seem to be a bit of a trade-off there. So I think that's the end, and I look forward to your questions.